So we'll get started. So good morning, everyone, and welcome to the Department of Pediatrics Grand Rounds. I'm Arabna Simpson. I'm standing in for Dr. Chakraborty this morning to introduce our speakers for the morning. And so the topic, as you know, is Beyond the Screen, Prescribing Nature for Our Children's Present and Future. And so I'll start first by mentioning that tomorrow is actually International and National Children's Day. And so we're fortunate to have Grand Rounds and this excellent group of speakers to present in honor of this day. And so I'll start with a land acknowledgement. Ottawa is built upon unceded Algonquin Anishinaabe territory. The peoples of the Algonquin Anishinaabe Nation have lived on this territory for millennia, and we honor them and this land. Their culture and presence have nurtured and continue to nurture this land. CHEO also honors all First Nations, Inuit, and Métis peoples and their invaluable past, present, and future contributions to this land. So I'll start by introducing Dr. Bennett, and then she'll introduce our speakers. So Dr. Bennett is well known to many of you, and she recently received her 35th year service award at CHEO. Sue is a pediatrician and mental health professional by training and was formerly the director of the Child and Youth Protection Program for over 2 decades and is now the director of social pediatrics, working with underserved populations and developing the discipline of social pediatrics in her research and education initiatives. She's a full professor in pediatrics and is the lead for community service learning at the Faculty of Medicine. Of relevance for our Grand Rounds today, she's just completed a Harvard-accredited course as a forest therapy guide and nature and medicine practitioner because she's not busy enough already. And so I'll turn over the mic to Dr. Bennett to introduce our speakers. Thank you, Dr. Bennett.
Thanks so much for your kind introduction. And welcome and bienvenue to you all. As you note, today's Grand Rounds are in celebration and recognition of National Child and International Children's Day, which is actually tomorrow. And our particular focus today is on the child's rights to access to nature, recognized under the United Nations Convention on the Rights of the Child. Now, today you will hear how that right is being supported by evidence, how that right is being implemented through social prescribing practices in the United States, the United Kingdom, and Canada, and how you as health practitioners can start nature prescribing today. As the world leaders are meeting at COP30 in Brazil, I will share an inspirational quote from David Attenborough. It seems to me that the natural world is the greatest source of excitement, the greatest source of visual beauty, the greatest source of intellectual interest. It is the greatest source of so much in life that makes life worth living. Another of his reality quotes, "There is no planet B." Before my introductions of our speakers, I would like to recognize a few special people at CHEO whose work resonates with our topic today. And Dr. Mark Tremblay is a global leader in pediatric physical activity and in nature. And as you're aware, most of you, he and his team recently gave a Grand Rounds for the launch of the Global Position Statement on Active Outdoor Play. Carol Fornataro, kindergarten teacher at our CHEO school, embodies the statement that there is no such thing as bad weather, only bad clothing. And for the last decade, she has ensured that her students are outdoors in nature for 40 to 80 minutes every day. I believe her limits are minus 16 degrees centigrade with wind chill. And Dr. Curtis Lavoie, emergency room physician who leads the Green Dream Team at CHEO. Thanks et merci to all others who are supporting our natural environment and our patients' access to it. So now I'd like to introduce our prestigious panelists. Dr. Cathy Jordan, PhD, is a professor of pediatrics at the University of Minnesota and principal scientist at its Masonic Institute for the Developing Brain. Cathy serves as director of research for a U.S. national nonprofit, the Children and Nature Network, which aims to lead a global movement to increase equitable access to nature everywhere children live, learn, and play. In the latter role, which she has held for over 10 years, she leads a team that locates, curates, and summarizes the scientific research about children and families in nature, and translates the evidence for general, practitioner, and policymaker audiences. She co-founded the Teacher Field School, an intensive, experiential, nature-immersed professional development program to train Minnesota elementary teachers to confidently employ nature-based learning approaches across the curriculum. Cathy is a pediatric neuropsychologist by training, earning her PhD from Wayne State University in 1991 and completing a postdoctoral fellowship at the University of Minnesota in 1995. Our own internally to CHEO, Dr. Robert Zarr, is founder and medical director of Prescribing America, a no-cost platform for doctors and other healthcare professionals to issue nature prescriptions as part of routine care. Dr. Zarr is a board-certified pediatrician and researcher. He was formerly at Unity Healthcare, located in Washington, D.C., where he provided primary care to low-income and immigrant populations for more than 2 decades. He currently works at CHEO's emergency department. Dr. Zarr is also a certified nature and forest therapy guide, and just to note, we now have 2 of these at CHEO, and previously served as an advisor to the National Park Service on park prescriptions. Dr. Zarr received his Doctor of Medicine degree from Baylor College of Medicine, a Master of Public Health degree from the University of Texas School of Public Health. And our third speaker, Dr. Kerryn Husk, and he's one of our social prescribing collaborators in our research. Kerryn is Professor of Health Services Research in the Peninsula Medical School and NIHR Applied Research Collaboration Southwest Peninsula, University of Plymouth. He is an expert in social prescribing, leading a research program around evidencing and developing social prescribing interventions. He has managed various social prescribing projects in the UK and internationally on the implementation, rollout, scaling, impact, and roles for social prescribing funded by UKRI, NIHR, EU Horizon, and others. He led the creation of the Academic Collaborative for the UK National Academy for Social Prescribing and has conducted extensive policy focus work for government departments, including the UK Department of the Environment, Food and Rural Affairs. Over to you, Cathy.
Thank you so much. I'm going to share my screen. It is a pleasure to be with you. Thank you so much for the invitation. I have been asked to give some research background about the impact of nature on children. At Children in Nature Network, we have a mantra. We say, nature helps kids be healthier, happier, smarter, and more effective stewards of the environment. So I'm going to tell you about what we believe are the most robust research findings in the first 3, the healthier, happier, and smarter areas, based on a review of research my team at CNN did informally in the summer of 2024. And then I'm going to dive a little bit deeper into some findings from a systematic literature review that I and colleagues from University of Sherbrooke in Quebec did, just published in last month, which was focused on effects of nature on the developing nervous system. The research shows that children are healthier when they live, learn, and play around nature. And this starts before birth. Mothers living in greener neighborhoods tend to have healthier newborns in terms of full-term babies with healthy birth weights. Then when children live in greener neighborhoods, they have greater physical activity, promoting healthier weight, and they may have enhanced immune function because of exposure to soil microbiota. You may have heard of the myopia effect. Dopamine, which contributes to the shape of the developing eyeball, is affected by sunlight. Without some sun exposure, improper dopamine functioning can result in an elongated orbit, causing nearsightedness. There are, of course, reasons for myopia, include other reasons, including too much indoor time, too much screen time, etc. But this dopamine and sun effect appears to be important as well. So those are passive forms of nature exposure. Active engagement through play and learning in natural environments tends to promote motor skills, as well as increased physical activity and decreased sedentary time, which is beneficial for various health outcomes in childhood and as kids grow into adults, such as reduced risk for chronic illnesses like adult obesity, diabetes, and hypertension. And importantly, it's often the children from the most disadvantaged backgrounds who have these health benefits from nature rather than, or at least more than, their peers who face fewer challenges. This statistical effect is called the echogenic effect, and it may help reduce health equity gaps. So research also shows that living in greener environments and engaging with nature enhances children's mental health and emotional well-being, the happier part. There are four major areas of mental health impact supported by the most rigorous research. The first is cognitive and attention restoration. There's lots of research showing that significant improvements in selective and sustained attention and reduction in ADHD symptoms can come from nature breaks, nature-based learning, time in the woods, etc. The second impact is lifetime psychiatric risk. Whereas nature breaks and short-term interventions affect things like attention, it's cumulative exposure to nature throughout childhood that is associated with later psychiatric risk. Children who live in the least green environments have a 55% more likelihood of developing a psychiatric disorder later in adulthood. The third impact is emotional well-being, mood, and emotional regulation. Nature can lead to increased positive affect and reduce negativity and rumination, psychological distress, tension, and anger. Finally, the fourth impact is stress resilience. Research on nature exposure shows that being able to view or be in nature speeds up the process of recovering from a stressful event. And I should mention that, again, nature-based interventions may promote the well-being of children with special needs, including symptoms, reducing symptoms in kids with ADHD and to some degree autism as well. And it could be particularly helpful for kids from disadvantaged backgrounds. Regarding smarter, nature improves academic performance by enhancing the cognitive functions, physical and mental health, and social emotional development that support learning. I'm going to talk for a minute about nature-based learning, or NBL, as I'll call it, because it illustrates the intersection of the healthier, happier, and smarter impacts quite well. By NBL, I'm referring to learning outdoors in a variety of subject areas, meaningfully using the natural environment as the context for nature, and natural objects and phenomena as the tools for instruction. It's more in and with and through nature rather than about or for nature, although that can also be part of it as well. It's just a little bit different than environmental education, which is really more about and for nature. In many studies, NBL outperforms traditional classroom learning. When it only matches classroom learning, the fact that it has these concurrent physical health, mental health, and conservation benefits gives it the edge over classroom-based learning. The research suggests that the academic outcomes of nature-based learning may be related to both the simple exposure to nature itself, as well as the characteristics of nature-based instruction. So with respect to the passive exposure, the nature itself, greenery surrounding the school, green views from school windows, the presence of green walls, or even just, plants in the classroom, these can result in greater academic success by supporting the functions such as the functions that support learning, such as cognitive functions like attention, memory, and self-regulation, emotional functions such as stress regulation, emotional regulation, and well-being, and social functions such as pro-social behavior and cooperation. These outcomes are important in and of themselves, but they are related to educational performance because kids just learn better when they're paying better attention, they're better regulated, less stressed, they're working better together. Similarly, active learning through nature-based instruction supports academic success through those same cognitive, emotional, and social functions enhanced through exposure to nature itself, as well as increasing motivation and engagement, because teaching in nature lends itself particularly well to what we know are high-impact teaching methods like inquiry-based learning, investigations, phenomena-based learning, social and collaborative activities, hands-on activities, and physically active learning. These teaching approaches increase student engagement and motivation, which enhances students' capacity to learn. And the whole class is affected as a unit. When each child is reaping the benefits of nature on self-regulation or motivation, the combination of all those individual regulated and motivated kids creates a regulated and motivated class where all kids have a better chance of learning. Lastly, and importantly, greening around schools and nature-based instruction can support students with special needs. Again, ADHD symptoms are the big one that we know about, but also emerging research, more and more emerging research on things like autism. And for kids from disadvantaged backgrounds, greening around schools and nature-based learning and play can play a particularly helpful role, possibly demonstrating that ecogenic effect as well. There are two theories that researchers explain much of the impact on nature on well-being. Attention restoration theory suggests that directed attention requiring voluntary effort and inhibition of distractions can become fatigued over time, such as when kids need to really sustain their effort to pay attention in the classroom. Nature can tap a second attention system, an involuntary, effortless system, allowing the directed system to kind of shut down for a while and restore. Then when you come back to that effortful task, you feel, restored and ready to go. The second prominent theory is stress reduction theory. It says that exposure to nature facilitates recovery from stressors. We have quite a bit of evidence showing that exposure to nature affects the peripheral nervous system in ways that reduce levels of physiological stress. So whereas stress ramps up the sympathetic nervous system, the fight, flight, or freeze system, nature counteracts that by ramping up the parasympathetic nervous system, the rest and digest system. So blood pressure, heart rate, cortisol, for example, all return to normal and you reach homeostasis. Attention restoration theory has been pretty widely studied, but understanding of how attention restoration theory is represented in the brain has been somewhat more limited. Although stress has been demonstrated to affect stress-sensitive brain regions such as the amygdala, the hippocampus, and the prefrontal cortex, there hasn't been much effort to kind of pull together research on nature's impact on neurobiological markers of stress recovery in those same regions. And up until now, there have been no systematic reviews uncovering the neurophysiological correlates of nature exposure of youth and children. So my collaborators at University of Sherbrooke and I conducted a systematic lit review, including 26 environmental neuroscience studies to uncover the impacts of nature exposure on all measurable neurobiological markers that might be affected by nature, including brain structure, brain activity, and peripheral nervous system activity in kids and youth 25 years and lower. This graphic sums up our findings. Nature conditions, the first column, consisted of either residential greenness, passive exposure, either by observing surroundings, if they were outdoors, or while observing natural elements such as images or window views if they were indoors, and active engagement such as through nature-based learning. Measurements could be taken either in the context of exposure only or while kids did a cognitive task in nature. Nature was found to be related to several types of nervous system outcomes. The middle column, structural changes in the brain, changes in brain activity measured by EEG and evoked potentials, and changes in the peripheral nervous system. First, this residential greenness was positively associated with children's brain structures. Specifically, the prefrontal cortical gray matter volume was higher with higher lifelong exposure to residential greenness, even when controlling for age, sex, socioeconomic status, etc. The prefrontal cortex is involved in decision-making and cognitive control, working memory, social cognition, which are crucial to children and youth learning. Brain activity is measured in two ways. First, measuring the blood oxygenation levels in specific brain regions over long periods of time, with the assumption that the more a region is activated, the more its cells will increase their metabolic needs, elevating the levels of blood flow. And the second measure is through EEG, both spectral analysis and event-related potentials. Both exposure only and exposure plus cognitive task studies compared a nature condition to an indoor or an urban setting. The changes in brain activity were dependent on whether nature was coupled with that cognitive task or not. In exposure only conditions, a global decrease in electrophysiological activity was noted, except for beta power, which increased when compared to control conditions, indicating a relaxed but alert state. In exposure plus cognitive conditions, cognitive task conditions, the brain activity was increased when compared to comparison or control conditions, indicating more effective attentional processing and efficient cognitive resource allocation when doing cognitive tasks in the context of nature. This adds a little nuance to the explanations proposed by the attention restoration theory. And finally, in terms of peripheral nervous system measures, which reflect experience of current stress or relaxation, at-rest studies measuring physiological indices like heart rate variability and pulse and heart rate reported lower sympathetic and higher parasympathetic activity after exposure to nature, indicating a decrease in stress levels and a state of relaxation. And this supported stress reduction theory. So the takeaways. The massive research can be boiled down to nature makes kids happier, healthier, smarter, better stewards of the environment. That may be particularly true for kids of more disadvantaged backgrounds. And the systematic review that I did with my University of Sherbrooke colleagues suggested that first, kids who grow up in greener neighborhoods are likely to have bigger brain volumes in some areas critical for learning and functioning in school life. When kids are in nature, whether it be through nature imagery, being able to see greenery from their school windows or sitting or walking in the woods, they're likely to enter a relaxed but alert state compared to an indoor urban environment. And third, compared to being indoors or in an urban environment, when students need to perform a cognitive task, doing that cognitive activity in nature enhances their attentional processing and allows them to complete the task with fewer cognitive resources. The research on nature's impact on kids is expanding exponentially and at the same time becoming increasingly rigorous. To help establish causality, studies are focused on better controls or quasi or experimental designs, as well as digging into possible mechanisms, including the level of basic function of the brain and brain structure. Research is also increasingly taking a developmental perspective, both in terms of how nature engagement intersects with the brain and behavioral development, but also taking a lifespan approach, looking at the influence of nature engagement and its outcome in childhood on adult functioning. And I will stop there and we'll pass on to the next speaker.
Fantastic. Thanks, everybody, for coming. To those who are in person and, of course, those who are online. Thanks to Sue for organizing, Dr. Bennett for organizing this, and thanks to Dr. Jordan for her initial remarks. I'm going to kind of dive in here and talk a little bit about park prescriptions or nature prescriptions and provide you with some evidence and implementation. I have no disclosures to make. All right, so what exactly is a nature or park prescription? Many of you are probably still kind of wondering what that is. And essentially, it's a kind of social prescription, which means that it is co-produced. So unlike a medication prescription where it's largely driven by the physician or the healthcare provider, we don't often ask our patients which antibiotic do they prefer to take, which medicine do they think is the most appropriate for their condition. In a social prescription, it really is co-produced. So questions about schedule, capacities, an opportunity for us as physicians or as healthcare providers to think about that, how to maximize the potential of being outdoors and to do it safely. And I've put up here on the screen an example of what is found in my organization called ParkRx America, which is also a platform to prescribe nature or park prescriptions. And there's 4 components to it. And what I'm talking about this in particular because this is the tool and the intervention that was used in a randomized controlled trial, which I'm going to talk about in just a bit, as the intervention itself. And there are 4 components. So place, activity, frequency, and a duration. The place is where the child or the client might feel safe and comfortable to be outside. As obvious as that may seem, it's an important question to ask because it gives you as a healthcare provider sort of insight into where that place is for them. It might be a local park, it might be their backyard, it might be a school grounds, variety of places. But oftentimes it does end up being sort of a park in the neighborhood. Activity. So what do they imagine doing in that space? With whom do they imagine doing the activity in that space? Will it be plugged in to ear pods? How will they do it? And what kinds of thoughts do they have about that actual activity? It often is a moving activity. It doesn't have to be. So it can be more of a mindful activity, which is usually less active, but not necessarily. And then the frequency. What days of the week might that happen? Afternoon, morning, evening, after school, before school, on the way from school back home, for example. Those are really important questions to understand to give us some idea of sort of the more practical side of this. And then lastly, the duration. How long can you imagine yourself engaging in that activity? Our platform also has a second part to it, which is the reminders. So we have all the bells and whistles with the electronics and technology to be able to send patients automatically, send clients automatically these reminders to fill their prescriptions, and they in turn are using those reminders to log the visits that they actually make to the parks. So there's this sort of tethering between the healthcare provider and the patient during that interval of time between one visit and the next. Now, there is some evidence out there, not a lot yet, in terms of the efficacy, the impacts of these park or nature prescriptions, but there's a limited number of studies. Not all of them are randomized trials. Some are more observational studies, but there is so far some evidence to suggest decrease in parental stress and some positive effects on mental health like anxiety and depression, some reduction in blood pressure, and also some reported increase in physical activity. Now, there are a number of studies that have looked at how park prescriptions or nature prescriptions have increased the number of visits, park visits, as well as time spent in those parks. And I'm going to dive right in as my segue here in terms of the study that we've just completed that has looked at objectively measured, that is accelerometer measured, changes in moderate to vigorous physical activity. So the picture on, I think it's your right as well, is some of my colleagues at Unity Healthcare. It's the federally qualified health center where I was for 20 years practicing primary care, where we actually were able to administer this randomized controlled trial. And one of the main points of this research was to see, the main outcome was to see whether there might be an impact on this moderate to vigorous physical activity. We did want to also look at some biological impacts to see whether we could have any changes in blood pressure, in BMI, body mass index, lipids, and A1C. We did also try to see if we could see any differences in mental health outcomes, cognitive function, as well as any age and gender differences. So this is a photo of the actual site, the main site. There are 10 different community health centers that are part of this federally qualified health center, based in Washington D.C. But most of the kids between 6 and 16 years old were recruited from primarily from one site, but from all over. So we had 514 kids were able to enroll and randomize. The mean age was 10. This is the clinic where I was at was where most of the kids were recruited. So I was not just the co-PI on the project. I was also sort of the clinic manager for this. The medical assistants, etc. So I was able to train 103 providers. 44 of those actually were at some point had delivered at least one nature or park prescription during that visit. We collectively were able to issue over 1,700 prescriptions over the course of 4 years. So we started this in March of 2020. So if you remember what that was the very beginnings of COVID in North America, which we thought we were a little crazy to do, but we decided to go for. We actually thought maybe about pausing the initiation of this randomized trial at that time, but decided we would go forward with it. And I'm glad we did in the end, and as you'll see why. And then collectively, this group of 44 providers, and they were physician assistants, nurse practitioners, family medicine docs, and of course pediatricians, who collectively saw that of those prescriptions that were issued, there were over 12,500 logged visits to parks. That's quite a lot of visits. Now, this is probably an underestimate because that second number on there is a self-report. And then also, lastly, I wanted to point out on this slide that 97% of those kids who were randomized to the intervention arm received at least one prescription. So this is to say that pretty well received. These are busy primary care practice physicians, healthcare practitioners who one would think from the literature don't have time to do this because time is listed as the main barrier, and yet did it quite amazingly. Took about 2 to 3 minutes of the visit, all in all, to have that conversation, do the prescription, and do the reminder. A little bit more about the population, the study population. So 6 to 16 years old, very, very connected to their electronic media. So this is basically a full-time job for them, 48 hours a week they're on their devices. And if you think about how much time they spend in physical activity, you'll see in a second down below. Not very much, so about 16 minutes in MVPA per day. We don't have a lot of comparisons pre-pandemic, but there was one study that looked at a Mexican-American group, youth, and they were already double that back then. So this is a very sedentary group of kids and very connected to their devices. So after 6 years of research, planning, applying for the grant from the NIH, administering it, analyzing the data, and eventually publishing manuscripts. This is the sort of distillation of that 6 years into one slide. So we're proud to say that it does seem that these PARC prescriptions that are being done in a busy primary care practice for kids from 6 to 16 years old during their well child visits, during follow-up visits, does in fact increase MVPA. So physical activity does go up, and this is objectively done, so using accelerometers. We were able to show that at 3 and 6 months, which we're very, very happy about. I know 2 minutes a day doesn't maybe seem like a lot to you, but when you think about only 16 minutes a day in MVPA, this is actually a significant jump. So very exciting news to see that. We also did see now the second two are survey data, so self-reported data. And these were done at baseline 3, 6, 12, and 24 months. But I'm sharing with you my manuscript, a publication that's looking up through the 12-month data. We also saw an additional PARC visit every 2 weeks at the 3 and the 12-month mark, as well as 30 more minutes that a child would spend in a PARC when they visited a PARC at the 12-month mark. So a little spotty there, but we're happy to see that at 12 months, which is really good news, because a lot of these studies that look at physical activity have an extremely hard time showing a persistence of this impact, the effect, usually past 3 to 6 months. So we got to 12, which we're very excited about. So we have other findings that I'll let you kind of read through a little bit here. I just wanted to point out that even though we were trying to look at biological impacts, so the blood pressure, as well as BMI, lipids, and A1Cs, we had all the baseline visits were done in person. However, the follow-up visits, that were done, each child was enrolled for 2 years. Now, the follow-up visits were done, they were split between remote and in person. And for Unity Healthcare, this federally qualified health center where we did the study, it was a huge change for us because we had never done remote visits before. So it was the first time we were doing it, and there was a little bit of a learning curve as well. But of course, there were decreased opportunities to get weight, to get height, to collect blood, things of that nature, to get blood pressure. So we just didn't have enough data this go around. So, and if in case anybody has forgotten about what happened in Washington, D.C. in 2020 and 2021, we had an insurrection there, lots of civil disobedience, and a lot of restriction on activity, just publicly. So parks were really not as available as they had been prior to the initiation of the study. So a lot of confounding, a lot of barriers in there, but we still were able to see something which we're very proud of. Now, one last piece in terms of some additional research that I was able to do was look more closely at the provider characteristics and how they might correlate to the prescriptions themselves. So it turns out that about 75% of those prescriptions, 1,700 prescriptions, were issued by pediatricians, largely because they see only kids compared to the family practice docs and the PAs and the NPs, and just had more time, more opportunities, because more patients who were enrolled in the study to prescribe. Well, it turned out there's a correlation between the frequency, the number of prescriptions that you've done, and what we call the prescription fill rate. That's simply the logged visits, those PARC visits, self-reported log visits, over the prescriptions. So it's a sort of a measure of like, how well are you doing when you do these prescriptions. So my own interpretation of this is that maybe there's a learning curve that goes on as you do the prescriptions. So as we do more of them, we get better at them, and perhaps there's sort of an increase in the sort of efficacy of those prescriptions themselves. I was also interested to look and see whether provider self-care, that is, how we take care of ourselves, the frequency, and specifically the frequency and duration of time outside in nature for providers, as well as the frequency of workday outdoor breaks. How often do we take a break? Seemed also to correlate with this prescription fill rate. So it seems to suggest that the more that we do that, take care of ourselves, the more likely we are perhaps to want to use this kind of intervention and for it to be effective. And the last is that we seem to see a correlation between the beliefs and attitudes of providers toward the prescriptions themselves, and the prescription fill rate. So the more that we believe in them, that they're going to work, the efficacy of them, perhaps the more they actually are going to work. So what's happening in Canada? Good news. So I talked to Laura, who's the manager of education at the British Columbia Parks Foundation, and she shared with me a couple of slides. So there is already in Canada, if you haven't heard, a platform to prescribe parks and nature. It's in every province, and 19,000 providers have signed up for it, as well as they've issued collectively 1.5 million prescriptions. So if you haven't had a chance and you're interested, I'll put the QR code here. And I think from my communication with Laura, there are already at least 25 CHEO staff who've signed up, CHEO docs who've signed up. And it'd be exciting to see if anybody from this audience would also like to sign up. Thank you so much, and look forward to any questions at the end.
Right, over to me, I think. So, my job in this 12 minutes is to give you a bit of a bird's eye view of what happens when you try and scale some of this stuff. And then whilst this view is from the UK, because that's where I'm based and that's where a lot of this scaling has happened, we do think there's a fair amount of translational information to carry across into the Canadian case. And I've done quite a lot of work with Canadian colleagues to do just that. So we've heard in the first two presentations how these sorts of approaches might work, what those mechanisms might be, and then when you take those interventions into the wild, what the impact may be and how you might measure those. I want to say something a little bit about how you scale this stuff. If you assume that you should, how do you do it? So we've had a few cases here in the UK which might be relevant. The first is that green social prescribing, the thing that we've just been talking about, has been rolled out nationally, and there's quite a lot of learning around that. That builds on the case that social prescribing itself has been implemented universally in the health system here in the UK. And of course, that involves young people, but there's an adaptation to social prescribing for children and young people. So I want to try and bring that together and try and look at the lessons around scaling for those things. Okay, so the
Maybe.
major program, hello. So the major program around green social prescribing that's happened here in the UK was a 2-year, £6 million government initiative on how systems can be developed to enable nature-based interventions to improve health. So this was funded through our treasury, and they were pilot projects to test innovative ways of working, including evaluation. But for me, the most important thing was that it involved broad partners. So this was our Department for Health, our Department for Environment, the NHS, lots of others. And it just showed real trajectory in terms of the direction of policy travel. And those partners were interested in how to embed green social prescribing at a system level. And their measures of success were that they wanted to reduce health inequalities, reduce demand on health and social care, and develop best practice for green social prescribing. So it's an interesting insight into what our policymakers wanted. So that program was rolled out. It attracted over 8,000 individuals, and when you look at the quantitative outcomes, unsurprisingly, you see significant improvements in health and well-being, as we've heard from the previous talks. Importantly for us, the targeting was effective. So when you try to get to people with poorer outcomes than those who are less engaged, these sorts of approaches do get to those groups. Those sorts of people do sign up, they do engage, and they do adhere. We tried to look at the economic impact across rolling this out, and we used something called Wellbees to estimate improvements in life satisfaction as a social return on investment. And we found that there was a return of $2.42 on the dollar, and it was cost efficient relative to other therapies that you. Okay, so this builds on scaling social prescribing in the UK, and I'm sure lots of people on this call will know a fair bit about this, but I wanted to give that context that primary care in the UK was changing in the late 2010s through to being far more personalized, far more embedded in community approaches to health. And primary care was really concerned with being very patient-led and building around prevention and public health. And so it was a really receptive context policy environment for something like social prescribing to fit into. And in 2019, our NHS long-term plan embedded social prescribing pathways and link workers into core health policy and funded link workers across the whole of the nation. So in theory, every single individual through primary care would have access to a primary care link worker. By the end of 2023, there were 3,500 of those link workers, and millions of GP consultations led to social prescribing. And those social prescribing referrals led to engagement with activities like green social prescribing. So it scaled rapidly, it was embedded in health policy, and it scaled effectively in that it reached, in theory, every single individual. Lots of good work around the impact of social prescribing, and unsurprisingly, there is a small improvement in basically all the populations that engage with those referrals. And there's lots of devil in the detail, so I'd encourage you to go and have a look at how that's gone. But I think one of the overriding findings from all of that work is that it's very difficult to trial an idea. These are not coherent interventions. They are ideas that have been implemented in different ways. What on earth does robust evidence look like in this space? It's a good conversation to have there. Um, so that describes an adult service. And that adult service was universal in principle, but not in practice. Of course, if you roll something out through primary care, it is likely to exacerbate and perpetuate those existing inequalities. And we know that we don't treat groups of people the same way in primary care. And so young people, quite frankly, just didn't take up social prescribing as much as other people. And so it also then followed that a lot of our existing knowledge and a lot of our research and a lot of our service and QI stuff was around adult entry points, adult experiences of primary care, and adult experiences of social prescribing. So there was a growing grassroots movement around developing social prescribing for children and young people and adapting these universal services to make them more appropriate for kids. This is exactly the sort of thing that could help. How do we make it how do we make it help? So there was a lack of policy, and so people started to do their own work and develop their own guidance and try and link it to existing bits of guidance in the health service. And that's where our research group stepped in and said, okay, well, actually, we need good evidence to try and understand where it is we position children, young people, social prescribing, rather than should we, where do we, and how do we? So we had a recent project through our National Institute of Health Research, and we wanted to do two things. We wanted to understand how it could be that those social prescribing pathways through primary care could be adapted for children and young people. How do those touch points operate for that different cohort? And secondly, if we're going to offer community-based activities like green social prescribing for children and young people, how is it those children and young people understand those community activities? What is it that their interpretation of those activities is? And do either of those things differ from adult services? We've got two reviews, literature reviews, one of which is in the public domain. I can send a link. The other one's coming out. I can send a draft. We also did lots of primary work, interviews, speaking to children, young people, professionals, service delivery. And the findings from those work packages won't surprise you, really. For those touch points and those pathways for social prescribing, there's huge variation across the different organizations that deliver them. From the referral source, for example, children and young people present in college, in school, to families, not just primary care. To the adults and the individuals that work alongside those children, that breadth was really important. And that has huge ramifications for how we set up children and young people's social prescribing, who you fund, how you fund, and how you make sure that people navigate it. We were able to distill some models, and all of those models for children and young people's social prescribing were cross-sectoral, collaborative. They weren't always linear, and they didn't always result in children making it to something like a green activity. And sometimes that interaction with somebody who was willing to listen to them and to talk and engage was enough. And so understanding the cyclical nature of those pathways, again, was really impactful for how we set up and deliver them. So our work package 2 tried to understand how community activities differed in the minds of our children and young people. And again, unsurprisingly, it was fundamentally different for children and young people than it was for adults. Um, our young people told us that they focused on the people rather than the places or the culture. So if we're thinking about a green, natural environment type social prescribing, it was the people in those environments and the ways in which those groups functioned and how they interacted with those groups that was important, as much as it was the places and the culture that they interacted with. So to return to my point about what does robust evidence in this space look like, we wanted to do a really large implementation study of children and young people social prescribing in the UK, but that wasn't considered to be particularly attractive to our funders. And we were told in no uncertain terms that we need to trial this sort of stuff. And we agree as a team, this is something that's important. So our next piece of work will be to say, if you contain a population of children and young people through social prescribing, does it become an effective way of treating them for particular symptoms, for the management of those symptoms, and then for the prevention of associated mental health distress? So we have a project looking at taking a group of newly diagnosed type 1 diabetes children through hospital and seeing whether social prescribing link workers as part of that care team is an effective way to prevent later mental health distress. We think it probably is, but that's a population that you can trial and there are outcomes that are relevant for that. And that will then contribute to the evidence around children and people social prescribing, which enables further implementation, we think. So to try and bring those threads together, green social prescribing for children and young people through those existing pathways exists, but it is quite patchy. There are little pockets where it's going incredibly well, but this isn't joined up at regional or national levels. And we know from our work around children and young people that they don't actually always reach those community activities anyway. So how is it that we support those pathways to be non-linear, to be diverse in terms of their entry points and exit points? And how can we do that at a local level whilst communicating nationally that we need the money to do it? And that's the thing that we've really struggled with, I think. So that pocket of good activity isn't always accumulated up in the way that it is for adult social prescribing. What are the main issues for scaling, we think, here in the UK? Well, funding and investment. Our voluntary sector, as I'm sure it is elsewhere, is not sustainably funded. They're often on short-term grant capture. They're trying to look after their staff. And they're being asked to deliver a lot of this stuff through the health service, which has a different funding setup. So trying to navigate some of that complexity is really difficult, continues to be really difficult. Eligibility. Who is it that are the young people that would most benefit from these sorts of services? How do we reach them and how do we make sure that we're not leaving pockets behind? What is it that a green social prescribing for children and young people pathway looks like and what reach should it have? I think we need to think very deeply about that. And then the last thing is currently here, it's quite difficult for us to link to existing structures, guidelines, care pathways, clinical pathways. And there needs to be some join up at policy level in terms of making those offers connect with what other services are around these children so that they can be delivered in a way that's most acceptable to not only the children, young people, their families, but also those organisations that are delivering those bits. So that's a bit of a top level view, and I obviously welcome any questions, and hopefully we've still got time, Sue.
About 10 minutes or even longer. The speakers are going to be available for a few minutes afterwards if there are questions people want to stay on.
I have a question virtually, if folks can hear me.
Okay. Thank you, Mel. Go ahead.
Oh, wonderful. Thank you. So first off, thanks for a great presentation. I have a quick comment and then a question. I think my comment is that in Canada, it can be hard to get people outside because people are so obsessed with the weather. But really, I love the saying, there's no bad weather, only bad clothes. I am not a tough person. Like, I like my comforts in life. I get cold, hot easily. But yeah, I just bought more clothes. If it gets cold out, put on more clothes and you can enjoy the winter. I honestly used to hate the winter, be miserable for 4 months during the year, but now I kind of enjoy it almost as much as the other years. So thank you for talks like this that motivated me to get outside and try to model that for the children. My question though is, I work in the emergency department like Robert, so I only see patients who are sick, and I would love to like bring this up because sometimes I do, meet kids where I think that this would be really helpful, but I worry in the context of them being unwell that families will feel invalidated and say, "Oh, I went to the doctor and I'm having frequent chest pain, but they said it was anxiety and told me to go play outside." Like, how invalidating is that? Is there any way that we can like efficiently have these conversations and make sure that patients don't feel like we're brushing off their very real problems and concerns while still recognizing that part of the treatment could be being outside more?
Yeah, thanks for the question. I'll turn it over to Dr. Zarr.
Hey, Mel, that's a great question. Certainly, now having worked myself in the emergency department for 3 years, yeah, it's a little more difficult probably in that kind of setting. I will, however, say that there's a wonderful, I think, wonderfully done short film that sort of really gets to the heart, actually, of what you're saying. It's about a former patient of mine, Jocelyn, who kept seeing me in the outpatient setting, in the primary care setting for chest pain. And she'd been going to the emergency room a number of times and being sent back to me. And so we had there's a film that was sort of done, sort of highlighting this transformative change in her as a result of a conversation that we had and then her filling this nature prescription. And I really went through those steps: the place, the activity, the frequency, and the duration. And when I asked her, Jocelyn, where might you feel comfortable being outdoors? She suggested being in a hammock, her dad's hammock at her dad's in the backyard. So for example, now, this didn't all happen all of a sudden. It took several visits. And so sort of the luxury of being in primary care, as you already know, is that you have that continuity of care. You're going to see them back many times. So it may not lend itself so much in this kind of an emergency department setting. But it certainly wouldn't hurt, to sort of like at least plant that seed, so to speak. I think it's reasonable to have that. Now, time is of the essence, right? So in any busy practice, whether it's the ED or an outpatient practice, but I very much believe in that stages of change model. So like, where is the patient? Where is the family in that moment in time? And recognizing that as a healthcare provider, I think helps a lot. So perhaps it's not the right moment to be discussing this. And then also to sort of like get back to the place and the activity, I think it's really, in my opinion, from what I have done, like prescribing hundreds and hundreds of prescriptions, is that it's really good to ask questions rather than sort of mandate things. So rather than saying, I need you to do this, I need you to walk 20 minutes a day, even though it's freezing cold outside, rather than that, asking them, what do you imagine doing outside? Where do you feel safe and comfortable? And make that your starting point. I hope that helps answer your question.
That's perfect. Thank you. And I see Amy Plint is wanting the link to the video if you have it. I think we'd love to see it. That's cool.
I can send it out. Yeah, absolutely. Maybe we can send it out. It's embedded within my organization's website, which is you can get to at parkrxamerica.org or natureprescribed.org.
Well, thank you. And then I see we have another question from Richard, so you can go ahead and unmute.
Thanks so much for a really inspiring talk. And on the previous comment this morning, I brushed off my winter bike and excited to get out and go for a bike ride through the woods today. So my question is, has there been any work on any non-inferiority studies around substituting this for pharmaceutical interventions? And obviously we don't want to completely abandon it, but there's this huge problem with polypharmacy. And could this be a solution to that?
I don't know if any one of our speakers wanted to take that question. Dr. Jordan, Dr. Husk online.
I am not aware of studies that have done that comparison. I think, as Dr. Zarr mentioned, this is an emerging area of research. There's a lot more that needs to be documented. I think probably before we even get to the stage of doing a comparison to something like pharmaceutical treatment. Exciting, though. Good idea.
I think I'd only add to that there is interesting work in adults around this, and that effect sizes tend to be fairly similar, but that hasn't been done with children yet.
Dr. Zarr's comment.
Just a quick mention. There was a study done maybe 10 years back. I'm blanking on the PI on the study, but I think it was out of the University of Illinois Champaign-Urbana, that did have two groups. A group of all the kids had baseline ADHD, and one group had pharmaceutical intervention, and one group had nature walks, I think is what it was, and I believe they had very similar outcomes in terms of their symptom checklist. So that is one. There isn't a lot that I know of either, but there is some evidence to suggest that this time spent out indoors in nature may be as effective, perhaps, as some pharmaceutical interventions.
That's a
And
Faber, Taylor, and Quo study, the University of Illinois one. Faber, Taylor, and Quo.
Thank you.
super interesting. And obviously, a thing that was not mentioned in the talk is that pharmaceutical interventions do have a large carbon footprint. So if there are alternatives that have a low carbon footprint and help preserve nature, that's just a win-win-win.
Well, having said that, may I? Yeah. So there obviously are some risks to nature and park prescriptions, right? And so part of the work that we do when we train doctors to do this, or healthcare professionals, is to sort of remind them, right, of the safety issues. And this has come up many times. So rather than dictating or mandating that a family or client go to a specific park, we feel that it's a little bit safer for the patient and family to ask them, where do they feel safe and comfortable? And you might have a better understanding of where that place is for them. And then, of course, the usual things, the weather issues, the falls, the violence potentially, the homelessness that you find in parks. So there's other issues that do need to be addressed, as well as, overexposure to the sun, dehydration, et cetera, et cetera. So there are other risks, but we also feel that those risks can be mitigated by having a good, quick conversation with them.
Just to make a comment as a clinician working in CHEO's mental health outpatients at the moment, it's not either or. I see young people who've been in the emergency room just days before trying to kill themselves. They're on multi-pharmacy. They've got lots of credential initials after their names. We're dealing with, really high-risk populations. So to get them off their screens, many of these kids are in their bedrooms, they're at home, they're isolated, but the screen issue is really, the title today, Off the Screens. If we can get kids off their screens with opportunities for things that bring them joy and meaning, nature's a possibility. There are many other, what are their interests and joys and dreams? We tap into their dreams, ideally get them off their screens, get them outside, ideally get them moving. But tapping into what's really a meaning in life for these kids is what we're after. We need to do the research, absolutely. I'm not waiting for it. We need to be, as pediatricians, we can working, as we've seen, we can working on these issues now by providing additive experiences for kids.
Thank you for that. And so that's a very fitting way to close the formal part of the Grand Rounds this morning. I'm mindful of time. It is 9:30, but our speakers have very kindly offered to stay on for an extra 10 minutes to answer some more questions. But in case people have to sign off, I just wanted to thank them for this really excellent presentation and for being here today, virtually and in person. And thank you everybody for joining us for this morning's Grand Rounds in celebration of International and National Children's Days. And so if you're able to stay on a little bit longer, then we can field a few more questions. Yes, go ahead.
Question, and I might have missed it earlier in the talk about, I'm a family medicine resident, and the prescribing nature part, is that just like a kind of, just like a, I don't know, like a, I can't think of the word, like almost like a gesture thing, or are there actual kind of financial background benefits of prescribing nature, like whether it's, like to have someone get access to a bus to get to a park, or whether it's winter here and helping them kind of get, whether it's like a small equipment, gloves or something to get access to the outdoors, because those are the things that I find with the patients I see, like public transit is like a big part of their lives and how to get access to these places. And does prescribing something actually come with like financial or benefits other than just kind of saying let's spend more time outside? And
right. Okay, and I'll paraphrase your question just for the people online. And so the question is about prescribing, like outdoor activity, and whether or not the park prescriptions, whether or not it's a gesture or if it comes with actual financial supports or other supports to actually facilitate the activity and engagement in this. So.
Yeah, it's a challenging answer. Your question, it's a good one, and it's one that's asked a lot. I'll sort of initiate the response by saying that if you can start to think of the social prescription, the park nature prescription as a social prescription first, because it really takes on a very different. It sounds similar. It is an RX, but it's co-produced. So those questions about finances does come into the question. Transportation. What are the perceived barriers? What are the real barriers to actually doing this? And even just like having that initial conversation is, especially for those of us who've done or have done primary care, it's sort of, we don't expect necessarily to solve the problem right then and there in that moment, but to at least initiate that conversation. So you don't always get to actually issuing a prescription in the moment, but you may get there over time, in weeks, months, or sometimes years it takes for people to kind of get to that point. But having that and asking those questions about place, activity, what the barriers be, is the way to do that. Now, having said that, there are many park prescription programs around the world, and everybody does them slightly differently. One of the things that I know in like in North America, we are looking into are to how can, let's say, insurance companies start to address some of those barriers. For example, the transportation or the fees. So I think, like, if you do get registered with PRX parks here in Canada, you'll see that some of those barriers have been addressed. For example, some of the fees will be for Parks Canada, for example, at least. I believe, I'm not 100% on this, but I think they are waived, right? So you have an entrance fee, or like the Museum of Nature, for example, here in Ottawa. I think if you show them the actual prescription, then that becomes your ticket in without having to pay. So, but there's many models for this, and I think there's a conversation that is developing over time as to how to address some of those barriers that might be there.
I'll just make a comment, and Kerryn, you might like to follow. In the UK, they have the government are funding link workers. So as health professionals, the primary care physician will then give the social prescription, it's my understanding, Kerryn, to the link worker, who will be addressing all the barriers and facilitate that through their relationship. We don't have that funding. I'd love to have that in Canada. I think the provincial government just gave some funding as a pilot a couple of years ago. But right now in Canada, I mean, for myself as a clinician, I'm doing a lot of the social prescribing link working piece with my team of medical students, which is great. They're totally enthusiastic, and they're navigating the community resources, and we're building the community map, but we don't have that. So, and it is a lot to take on to be addressing the barriers in a clinical practice. But the link workers are, or whatever we call them, they've got different, we're calling them community connectors. They've got different names across the world.
And I have a question. Oh, sorry.
So, did you want to, sorry, Kerryn, did you want to make a comment about that?
Only, I think, to say that I agree with everything Robert's just said, and that it certainly isn't a panacea to have some money thrown at a link worker, because you're kicking the can further down the road. The question still applies: who is paying for the activity, who's paying for the facilitation? Yeah. And that problem hasn't been navigated particularly well here, I don't think. So at the moment, equipment and travel can be paid for to those activities, but the voluntary sector is still providing the activity either for free or at a discounted rate. So that's still a conversation that has to be navigated. There's a deeper point about, we're asking something of a health from the health service, of the voluntary sector, that isn't being funded. How do we do that? And it's often navigated locally and often very well, but not by design.
I'm finding that we've got incredible resources within our community when we explore that. And for example, right now, the NAC, the National Arts Centre, are contributing a few $1,000s for us to have prescriptions at for arts activities. We've got a number of agencies, and from the federal museums, we're hoping to get contributions. This is for our research project anyway, but if we can have a system in place that, we can get donations to our patients for Children's Hospital, that would be great to have that over the long term. But you're right, we have to build up that. But it's community engagement. This is strengthening our community. That's another impact that we can look at from social prescribing in itself, with community engagement and the strengthening and connection of our community.
Access to, like, something I find in my clinic practice is knowing what the social resources are is actually quite hard. You don't know what you don't know, and if like part of the resource of the RX, your website RIPARX or something, if part of the resource of the website was in gathering, I mean, it's hard because there's so many cities around North America to do this, but if there was a resource around for each city, like having a list of all these local resources and the programs for admission, like for these, whether it's museums or parks, that would be such a good resource for clinicians to have access to.
Absolutely. We're actually in discussions right now for funding for the development of an AI companion to do this. So you're just a couple of buttons and you're going to know where to go for which activity rather than Googling and going to websites, making phone calls. It takes so much energy. AI could be an AI companion could be very helpful.
If I may. So one of the things that we've been struggling with, and finally I think have like kind of hit a tipping point, which we're very excited about, at least south of the border. So that, and we have a different model the way we do it south of the border than in Canada. But I will tell you, we partnered with the Trust for Public Land, and you mentioned resources, and we think probably one of the most important resources in this work, to be honest, is to know where the parks are. Right, to know where that green space is. So we now, at least south of the border, have over 150,000 parks that are embedded inside of this park or nature prescribing platform. It's not to say that it's our intention to as healthcare providers to find that place, but it actually does sort of help facilitate that conversation, and it gives us some sense of like, where does my patient client go? Where is that neighborhood of theirs? Because we can't know everything during that visit, especially if you only have 2 or 3 minutes to do this. So by having all of the parks, like a database of parks, which we now have done, I do think it's sort of addressing at least one of those barriers and giving you some sense of what's there. We even have on there now, thanks to the Trust for Public Land, some additional information like tree canopy, for example. That's pretty important, right? There's a study that just got published last year that showed the higher the number of mature trees in a park, the longer a person spends in that park. And we know from lots of research that trees are good for us. So there's a lot that is happening. I would also just say to you and to anybody who's interested in doing this, try it. The risks are very low, and it's worth the experience from even our perspective to see what it's like to do that, and to have very low expectations when you first get started, because it's a little awkward. The very first time you prescribed amoxicillin, you weren't sure what you were doing, right? But now you've done it so many times, you've treated so many infections, you're pretty good at it. And there's this learning curve as well, I think, for social prescriptions.
Thank you.
All right, thank you so much. I did have a question about the idea of scaling up and opportunities for partnering with schools or other, has that been tried, or is that part of the approach at all?
Actually, yes, Cathy would be the expert on that, but just to say that Jane Goodall, may she rest in peace. She's having, there's a memorial actually from Toronto this Saturday. Just was an inspirational leader, and just to recognize her Roots and Shoots program that can be implemented. That's something I'm hoping to do with our local population. But Cathy, please take that question.
Sure. I know, I was just going to try to Google this. I know of a study of school nurses being trained to do nature prescriptions, and my recollection is that if the nurses were trained appropriately, the thought was that was a great route to this sort of prescribing, because it is where the kids are. They spend a ton of time in school. I can't find the authors of that study off the top of my head, or a quick Google search right now, but I know it's out there.
I don't know if there are any more questions online. Doesn't look like there are many questions in the room. So thank you all again for presenting today and for being here and for attending and sticking around for the extra time to answer everyone's questions. Really appreciate it. Okay, so bye everyone. Take care.